Hello, we're back and talking about acute kidney injury. So this is probably the most relevant for those of you that'll be working inpatient medicine. Here are the objectives. So we're going to describe the three etiologies of elevated creatinine, explain the limitations of using creatinine, and name the interventions for AKI based on their cause. So acute kidney injury, of course everyone's fought about this definition for a long time, but a 50% rise in serum creatinine or greater than 0.3 in 2 days. So that includes a lot of patients when you come down to it. 2/3 of the ER visits with elevated creatinine are pre-renal. So this is good news, and we'll talk about the difference between all these. They get better with IV fluid. So if you give somebody who's currently pre-renal a liter or two of fluid, they should, within a few hours, start making more urine and their creatinine should start coming down. Unfortunately, only about a third of inpatient AKIs are pre-renal, so giving them fluid may not help. Somewhere around 8 to 16% of people will develop an AKI while they are hospitalized. And outcomes are quite bad. There's a 4 times risk of mortality with an AKI compared to those that don't have an AKI. So here's a case study. We've got a 68-year-old female coming in with hypertension and a baseline creatinine of 1,2 who presents to the ED after 4 days of nausea and vomiting. So her electrolyte panel is below. I just want you to think about, as we go through, what other tests would you order? And we'll come back to this slide. And what other information would you like? So pre-renal is the first thing we think about when the creatinine is up. Can we just give this patient some fluids and things might get a little better? So 70% of ER visits for elevated creatinine are like this. You give them some fluid, they start making more urine, their blood pressure increases, they tend to do pretty well. It's characterized by a low urine sodium, and this is because when the kidney gets poor blood flow, like in a case of dehydration, the first thing it does is take sodium and reabsorb it. So it doesn't let any go out in the urine if it can help it, because it sees that as a way to increase blood flow to itself. There'll be a high specific gravity, and this just means the urine's concentrated. So this is done by the tubules. They reabsorb water, and so you end up with low urine output, but it's very high concentration. And then when we look at a urinalysis, the casts are something we look at, and I'll just say in pre-renal injuries, you may see hyaline casts, which are kind of clear casts, which are just indicate low flow through the kidney. I put a link here to urine casts for those of you interested in looking. It's a good thing to save, but a big topic, so I won't cover it all right here. If you see granular casts, or what we call muddy brown casts, that's usually typically a ATN situation. So a high BUN to creatinine ratio, usually anything over 20 to 1, suggests some dehydration. This, much like the sodium reabsorption by the kidney, the BUN is seen as an osm that can hang on to fluid and increase your blood pressure. The creatinine is not seen that way by the kidney, so that's allowed to go through, but the BUN gets reabsorbed and gets higher in the blood. The fractional excretion of sodium is really taking that low urine sodium and then also factoring in how much filtration is going on. So you're going to need a urine creatinine, a urine sodium, and then the plasma levels of those. And it'll give you a percentage of how much sodium the kidney is keeping. If it's less than 1%, it's indicative of a pre-renal injury. Greater than 3% is typically thought of as an ATN or intrarenal injury, and 1 to 3% is kind of indeterminate. I will say this is ordered quite frequently, and unless their urine output is really low in the oliguric, less than half of a liter in a day, it really can be a little misleading. So I usually only suggest a FENA if a patient's urine output is truly low. Post-renal injury is something we see in nephrology once in a while. It's not typically a nephrology problem. You're ending up forwarding your consult to a urology. But the first thing to do is put in a Foley and see, particularly in old men with prostate problems, sometimes that can solve the problem. We'll obtain a renal ultrasound in most cases to make sure there's no hydronephrosis, which is a swelling of the kidneys, which indicates they're having trouble just getting rid of urine. It typically will have a very fast creatinine rise, and I'm very suspicious with any sort of intra-abdominal surgery, urological surgery, gynecological surgery. But the big things to do, put in a Foley if you're calling me for low urine output, and get a renal ultrasound. And these things are usually ordered before they even consult us. So once you've ruled out a pre-renal injury and post-renal stuff, you can't pawn anything off on urology, then we're dealing with an intrarenal or intrinsic AKI problem. And we typically think of the nephron and try and think of where it could be injured. So this brings you back to the glomerulus, the interstitium, vascular, and the tubules. So glomerulonephritis is a primary kidney problem where the glomerulus is letting through all sorts of things it shouldn't. Typically, there'll be protein and it's greater than 1 gram per gram of creatinine. And we measure it like that because if you just measured raw protein, it would really vary quite a bit depending on how much volume of urine that you're measuring. So in order to kind of create a standard, we measure it compared to how much creatinine the kidneys are getting rid of. And thereby, it doesn't matter how much urine volume you're dealing with, you're comparing it to something else that's also being filtered. So hematuria is common in the inpatient setting, but that's because we have a lot of Foley catheters or even straight caths can cause RBCs in the urine. But if you see red blood cell casts, that's a big red flag because in order for a red blood cell to be caught up in a cast, and remember that's protein that the tubules are enveloping things in, it has to come from the glomerulus. So if it happens past the glomerulus, it will just be red blood cells in the urine. But if they're casts, that means something's happening way up at the glomerulus level. So sometimes you'll see actually low blood protein because there's enough protein leak through the kidneys that their blood protein or albumin will be low. So this is another way that the kidneys cause people to have swelling because the low protein actually causes swelling due to the low albumin and third space leaking of fluids. So glomerulonephritis is a big topic in the kidney world, and this is what some nephrologists focus their whole practice on. This isn't something you're going to see a lot of in the hospital, but again, we want to make sure we're not missing any of these. So that's why I put the big red flag next to RBC Cas, and if you have low blood protein and any protein in the urine, it's something to keep an eye out for. Interstitial nephritis. So this is an allergic reaction in the kidney. It usually requires a biopsy to truly diagnose it, but the first thing to do is stop the offending agent. So oftentimes we'll start an antibiotic or some other medication. I linked a list here. There are many, many medications that can cause this. But the first thing to do is to stop the medication. And then you can give steroids, and that can sometimes help. The typical course is you start a medication, and somewhere between 5 and 7 days later, the creatinine starts to rise. There's all sorts of associated things like a rash or eosinophils in the urine, but none of them are very specific. So it's really a clinical diagnosis. And if you're strongly suspicious of it, you can do a biopsy and you'll see interstitial inflammation essentially. So just be wary that if your creatinine starts rising, and it usually doesn't go up very fast, it's like 0.3 grams per liter per day, and it usually starts 5 to 7 days after starting a medication. Just have your radar up for essentially an allergic reaction in the kidney. So the third structure in the nephron is the vascular part. So it can certainly be the renal arteries, which are involved in things when like bypass surgery. Anybody who's had a stroke could have something go to their kidney as well. PE. We talked about, if their toes have showered with emboli, you can pretty much think their kidney might have the same sort of features. But I think mostly what we think about with vascular injuries is the microangiopathy. So these are the small, small blood vessels that go to the glomerulus, and they are essentially capillaries. So there's some syndromes called hemolytic uremic syndrome, which is the HUS, and the thrombotic thrombocytopenic purpura, which is TTP. And hematology usually has to be involved and look at a peripheral blood smear. But the reason I put these in here, they're hard to catch sometimes, but if your patient has an AKI with low platelets and you're not sure why, it's something to think about. Especially with TTP, we actually have a treatment. We can use plasma exchange, and it's effective in treating TTP. So if low platelets, AKI, have this on your radar. And of course, DIC with many, many organs can cause vascular injury. The kidneys are no different there. So once you've looked and kind of ruled out some of the other things, what you're usually dealing with is acute tubular necrosis, or ATN. So this is the majority of inpatient AKIs, especially in the ICU. Usually it's secondary to low blood pressures or medications, typically antifungals like amphotericin B, polymyxin B, antimicrobials like vancomycin. All of these are fairly stressful to the kidney, so they can cause ATN, especially when you combine them with hypotension or poor blood flow. So other causes, intra-abdominal hypertension. So these are patients, think pancreatitis, think perforated bowel. You get inflammation and high abdominal pressures. The kidneys get squished by the pressure or have some sort of reaction to that. You can measure this with a Foley, and if the pressure is certainly over 20, we start to think that the intra-abdominal hypertension itself is causing the kidney failure. These patients, usually have to end up having their abdomen open to relieve pressure, and over time they have it closed. Hepatorenal syndrome, cardiorenal syndrome, these are both secondary to other organs failing, and this too can cause basically difficulty for the kidney hemodynamics to be normal. So when somebody has reversal of portal flow in their liver, the kidney just does not get adequate blood flow, even if their blood pressures are fairly reasonable and 90s or 100s and not on vasopressors. Cardiorenal syndrome, causes fluid overload, which in and of itself can cause kidney failure as well. So the underlying thing to do is to treat the underlying issue. So if a patient is having hepatorenal syndrome kidney failure, they need a liver transplant. And if they have cardiorenal syndrome, they need an LVAD or a heart transplant, or sometimes dobutamine is enough to keep the kidney happy for a while. So ATN in general, there's no specific treatment other than supportive care, but the good news is it usually gets better if the underlying issue is treated. So you have a septic patient, they come in, blood pressure's low, they get put on pressors, they get put on anti-infective agents, and if the insult is short, when we're talking a couple days, usually the kidneys can turn the corner and improve. So here's a few things to keep in mind when you're dealing with AKIs, that injuries are cumulative. So if you have a hypotensive injury, let's say a patient has an arrest and the creatinine's going up and all of a sudden they get an infection and they're on 2 pressors. So the cumulative effect of that is worse for the kidneys than a single injury. I know that seems obvious, but every time you add some sort of nephrotoxin, it just gets worse with every insult. And part of that is because under normal circumstances, kidneys are very good at auto-regulating the blood pressure to themselves. So if the blood pressure drops, the efferent arteriole squeezes down and increases the glomerular pressure, keeping the GFR up. So that mechanism is blunted with pretty much any AKI. So they're more sensitive to hypotension. And I'd say this is true even up until they are fully recovered. And things like interstitial nephritis is easier to activate when patients are in inflammatory states. So if the immune system is already amped up, there's already eosinophils running around trying to do their jobs, and then you add a medication that the kidney reacts to, it's going to happen much faster and it's going to be worse. So these are things to keep in mind when you're managing AKIs. So we'll take a moment and talk about contrast, because this is a very common question I get asked in the hospital. Can my patient have contrast for a CT scan to rule out a PE, rule out a stroke, to look for some sort of abscess? So the history of it is that iodine-based contrast has been studied in mice and rats, and it does cause constriction of the afferent arteriole. And it also has a secondary effect of being a tubular toxin. So if the dose is high enough, it does cause an injury, and especially if you've already got a low GFR because of ongoing injury or CKD. It has been studied in EDs and in cath labs that the rate of AKI in these patients who are having acute MIs or getting ruled out for PE actually does not change with giving contrast versus not giving contrast. So oftentimes it is actually the underlying disease process that is causing the AKI rather than the contrast. Ultimately, there is no absolute contraindication to giving contrast to a patient. My question on the nephrology end is always, what do you think you will miss without the contrast? So if it's something important and they really need to rule it out, you can give contrast and we will deal with the repercussions. If the issue being studied is not reliant as much on contrast, then I really do try and keep my patients from getting the contrast. And once somebody is on dialysis, contrast is a non-issue and they can receive contrast anytime because it cannot hurt those kidneys anymore. MRI contrast for gadolinium is the complete opposite. So in somebody even with relatively poor kidney function, I'd say anything 15 or over for a GFR, can probably safely get gadolinium. It is eliminated by the kidney and it is not toxic to the kidney, but it causes gadolinium deposition disease if it is absolutely not eliminated by the kidneys. So if you look on Google and look up gadolinium, some of the first things you'll see are lawsuits related to this gadolinium deposition disease because it is quite painful and there's no treatment and ultimately can cause death. So radiology often will be the ones that will not want to give the gadolinium, but it is okay if patients have any sort of reasonable kidney function. Going back to our case study, we've got our 58-year-old who's coming into the ED after 4 days of nausea and vomiting, and baseline creatinine's 1.2 and it's now 3.2. So first things that came to mind for me are a urine sodium and a urinalysis. So I'm not sure exactly how much urine this lady's making quite yet, because she just came to our ED, but a urine sodium would tell me if it's low that she's dehydrated. So the urinalysis would also help rule out any CAS. The other thing that gives me a suspicion that she might be dehydrated is her creatinine's about 3 and her BUN is 77. So you would expect it to be in about the 30s if it were a normal BUN to creatinine ratio, but it's well over 20-1. So her orthostatic blood pressures would be helpful in this scenario, and there's a link there on how to do them. You have your patient lie down for 5 minutes, take their blood pressure, heart rate, lying down, sitting, standing, and any change in the systolic of greater than 20 or diastolic of greater than 10 or any symptoms are diagnostic of a orthostatic blood pressure. So this also tells you that they're dehydrated. So I would have them put in a Foley, get a renal ultrasound, and unless this woman is quite overloaded on exam, I would give some IV fluid and see if we can get those kidneys making some urine. I would do that before I would start treating the potassium, the bicarb, or the high sodium. So going through our steps on our case study, we're going to think about pre-renal kidney injury, which low blood pressures or an orthostatic drop would help make the case. A urinalysis showing hyaline CAS. We already know that our BUN to creatinine ratio is greater than 10-1. It's probably 25-1. And if her urine sodium came back, I'd say under 20. These things would all suggest a pre-renal injury. Now, if the urinalysis show granular CAS, if she's non-responsive to some IV fluid within an hour or two, or if the fractional excretion of sodium is high at 3% or greater, those things would tell you that she may be in the intrarenal phase. And to rule out post-renal issues, you put in a Foley, get an ultrasound, rule out any hydronephrosis. Now I'll just pause here and say that any pre-renal injury, if it lasts long enough, turns into an intrarenal injury as the tubules stop being able to work as well because they're just not getting enough good blood flow. So kidneys can be in a prerenal state for quite a while, but they do progress into some sort of a mix of prerenal and intrarenal, and then eventually an intrarenal injury. So now we're in management of AKI. We've given some fluid in the ED, the patient's being admitted, and now it's time to manage their AKI. So what we do is correct the underlying injury. We try and treat their sepsis, treat their hypotension, give them fluids, put them on antimicrobials. Once they're fluid resuscitated, we start some vasopressors if blood pressures are still low. Try and switch medications if there's a nephrotoxin in play. Fix the obstruction issue if there's a urology intervention to be done or if there's hydronephrosis seen on ultrasound. And then I'm very frequently asked if diuretics are okay to give a patient with an AKI. And my stance is we always need to decide where our patients are. Are we volume expanding still? Are we giving fluids to try and increase their blood pressure? Do we feel like they're volume resuscitated and now we're just maintaining? Or did we overdo it and now we need to take fluid away? So diuretics are always safe as long as you're not in a hypovolemic state or you won't make a patient hypovolemic. A lot of this will depend on how much fluid a patient gets in a day. So if a patient gets 3 to 4 liters because they're on multiple vasoactive drips, heparin drip, antimicrobials, you may give them a diuretic just to try and get them to make 1 liter of urine, even if they're going to be net positive for the day. So just always try and remember what your goals for fluid management are. And then we evaluate the creatinine daily and monitor for indications for dialysis. There's no magic number that indicates a patient needs dialysis. A single creatinine number actually doesn't tell you very much. You need to follow it day to day. And a good trick is to graph it out and see what's happening with the creatinine. If it looks like it's kind of rounding a corner and plateauing, you may be able to just ride it out and not consider dialysis. If it's going up very sharply and making no signs of slowing down, it may change our planning. Many patients recover on their own. We often need to just create the right environment, and if that happens fast enough, we can avoid having to do things like placing lines and starting dialysis. So hopefully your patient will recover with or without dialysis. Here's what to look for. Urine output always happens first. I tell patients or family members the first thing we usually see is urine, and that's usually at least half a liter in a day before we start really looking closely at the creatinine. The creatinine may not come down for several days, but urine output is the first thing we look for. And kidneys are really good at getting rid of potassium and getting rid of water. They really just have a hard time hanging on to these things is probably a better way to put it. So if they're hypokalemic and their creatinine is leveling out, replace it fairly aggressively. And these patients typically get hypernatremic because the kidneys just get rid of so much water and you just have to replace it. So I put a calculator here to calculate the free water deficit. And when we say free water, we just mean water free of electrolytes. So you can give that either down a feeding tube via an IV in the form of D5, or if patients are taking PO, they will correct it on their own because your thirst mechanism is very primitive and very strong. So even if your sodium is 145, these patients will be desperately looking for water. And once the creatinine starts coming down, recovery is well on the way, and we're usually pulling dialysis catheter at that point and high-fiving everybody. Here are some references and further reading for things talked about here, and we're going to move on to talking about dialysis.